for coming. Welcome to yet another rousing Wednesday IHME seminar. Thank you for being here. It's my pleasure to introduce our seminar speaker today. Rodrigo Moreno-Serra is a health economist from Imperial College. He works in the Center for Health Policy. He's done work for the World Bank as well. And he has worked with a number of people that the Institute we know well, and has really interesting research, especially along the lines of financial risk protection and universal health coverage. So I think that's what he's speaking on a little bit today. And he's asked that, like, points of clarification, questions, you're free to ask throughout, kind of real quick answer sort of things. But if you're looking for more of like a discussion or more of a challenge or something like that, maybe save that towards the end, make sure we get all the way through the main presentation, and then we can have a discussion the last couple of minutes. All right.
Well, thank you very much. First of all, thank you for inviting me to come here. It's a great pleasure to visit IHME. It's my second time here. It's well worth the trip, the long trip from Britain, so apart from the jet lag. So as Joe was saying, that I'm a health economist. As a brief introduction, I was born in Chile, raised in Brazil, and I've been working as a researcher at Imperial College London for a few years now within the business school and the Center for Health Policy housed there. For today, I thought it would be a good idea to speak a little bit about some of my ongoing work on universal coverage and population outcomes at the country level, which is a joint venture with Peter Smith, also from Imperial College, and with Lara Brearley from Save the Children UK. What I'm going to present today is pretty much work in progress, so any comments and suggestions are more than welcome. But part of it, we've already started the analysis, and part of that analysis is coming soon in the Journal of the Royal Statistical Society. So there is a part of it that's already work already done, but a lot of the things that I'm going to present today is work in progress. So please bring your comments, going to be very welcome. So just as a little bit of background to this particular work. So as you know, you very well know, the push for universal coverage has been under the spotlight recently, particularly after the publication of the 2010 World Health Report. So countries have been urged to make progress towards universal coverage, which has been defined as providing all people with access to necessary health services of sufficient quality to be effective without financial hardship associated with their use. So according to this basic definition of universal coverage, there are at least 3 ways countries can use to try and improve their levels of health coverage. The first one is by increasing the number of people who have access to a given package of services funded through pooled funds. The second way is by increasing the range of services people have access to from a given pool of funds. And the third way is by reducing financial barriers to access, or reducing the amount of money that people have to pay out of pocket when they seek medical care, or increasing financial protection, in other words. So you can see here that from this basic definition, the key element is pooled funds. So this refers to money that people pay before the need of medical care through sources like general taxation, social insurance contributions, or voluntary health insurance payments. And their role is to subsidize, either partially or in full, the cost of healthcare treatments. So people don't have to pay out of pocket the full cost of treatments when they seek medical care. So if you take this basic definition, then you can think of progress towards universal coverage as being equivalent to a higher prominence of pooled prepaid health spending in the total financing of the system. Now, why is this important from an economic perspective? Well, basically, because this is a matter of resource allocation in the public sector. In practice, in most countries, pooled health spending is basically government health spending, and governments have been urged to keep increasing their levels of public spending directed to the health sector. And one of the main arguments by the advocates of universal coverage is that by expanding coverage, countries will necessarily see improvements in population outcomes, and those improvements will then make such investments worthwhile. So that's the basic argumentation. The problem, though, is that much of the empirical literature in the area has actually found ambiguous relationships between indicators of system coverage and population outcomes at the country level. Now, this may be due to data limitations or failure to account for potential confounders of the relationships between indicators of system coverage and outcomes. But it may also be that the relationship between indicators of coverage, such as pooled health expenditures or government expenditure, and outcomes at the country level, they are intrinsically ambiguous. So, for example, in theory, you could envisage a situation where an increase in government health spending is followed by a commensurate decrease in private expenditures, for example, without any changes in the total financing of the system. And even, so households may, for example, decide to divert their resources away from voluntary insurance payments once government increase their funding of the system. And then you shouldn't have to expect any particular improvements in population health because of this change in the source of funding. But then, even if additional government spending increases the level of pooled health financing, then those additional resources will probably only have an effect in health outcomes if those resources are spent on high productivity inputs. But they may instead be spent on low productivity inputs, for example, a better tertiary care when the real gains are in extended primary care. Or they may be spent on services without complementary networks, for example, more health clinics or hospitals when there are no roads for people to get to those places. And even if these additional resources then increase the level of financing of the system, those resources may end up being captured by smaller sections of the population, those who are already better off, if the most vulnerable don't have the conditions to get to the health facilities to benefit from subsidized healthcare. And the same is true for private spending. I mean, if there is an increase in the private capacity to pay privately for healthcare, this may lead governments, for example, to decrease their funding of the health system in a commensurate way, so without changes in real service provision. But even if private spending increases, it may be the case that some of those additional resources are actually spent by people who can afford to pay, and they can get better access to better quality care, for example. In that case, there may be some population gain. So all of this to say that, in theory, the relationships may be ambiguous. And what seems from the available empirical literature in the area is that the empirical literature reflects those ambiguities that I've just described. So the early literature, for example, summarized by Phil Musgrove some time ago, finds no systematic evidence that additional government spending or total spending on health leads to any changes in general mortality indicators. And the same is true of a study by Dion Filmer and Lamprecht that focuses on child mortality. More recent, though, some studies using a wider range of explanatory variables and, in some cases, better techniques, they have found some evidence of improved child and adult health outcomes due to increased pooled expenditures, including some work that I just mentioned to you that is forthcoming. But in general, the evidence for low and middle income countries isn't that conclusive. What most studies find is that when countries, low and middle income countries, expand coverage measured by increased enrollment into public insurance scheme or private insurance schemes, the beneficiaries of those insurance schemes, they improve their utilization of healthcare services, as one would expect. And the financial protection levels of those people increase as well. So people are better protected against financial consequences of illness. But those benefits for those particular enrollees don't seem to translate very clearly into better population outcomes when you analyze at the country level. And the same has been found for increasing private expenditure. It's often higher private expenditures are associated with worse outcomes if that spending is through out-of-pocket. And there is evidence only from a couple of case studies that enrollment into private insurance schemes leads to better self-assessed health. But this is basically a couple of case studies, and there isn't virtually any evidence from a cross-country perspective. So what we want to contribute is actually the goals that we have in this paper are actually twofold. The first goal that we have is to contribute to the hard evidence base on the causal links between higher levels of system coverage measured by pooled health spending and population outcomes at the country level. So this is the basic, the first basic objective of our work. And we already started to explore this question in a previous work for a shorter time series. And the second question that we want to answer in this particular study is whether for a given health budget, the health impacts of additional pooled health spending vary according to how equitable countries are, not only in terms of access to their health systems, but also in terms of other important social determinants of health that may end up influencing the patterns of access to healthcare. Now, getting at those issues empirically isn't a trivial matter, particularly because of the possibility of endogeneity of coverage measures such as pooled health spending. The main problem here is that on top of the possibility of omitted factors affecting both health outcomes and the levels of system coverage or levels of pooled health expenditure, there is the important possibility of reverse causality or simultaneity in this relationship. It seems very sensible to expect not only that health outcomes will respond to changes in pooled health expenditures or coverage measures, but that coverage measures themselves will respond to changes in population health. For example, governments may decide to increase their levels of spending in the health sector precisely as a way to tackle increasing child mortality. And if that's the case, you're going to end up with a positive, spurious association between higher levels of pooled expenditure and higher levels of mortality, child mortality or adult mortality. Unfortunately, I don't think that most of the literature in the area has addressed those issues adequately. Simple OLS regressions are probably only identify correlations in the data, and even when more sophisticated methods have been used, for example, instrumental variables in a couple of cases, the studies have focused mainly on specific insurance interventions in specific countries, or they have used basically cross-sectional data, which makes it very difficult first to generalize the results to other contexts, and mainly to address potential sources of endogeneity such as simultaneity or reverse causality. In our work, we try to contribute to the literature by using a methodology, an instrumental variables methodology that is particularly suited to deal with, particularly with the issue of simultaneity and reverse causality. And we also use very long panel data to try and get at those issues. So let me get to how we try to study this question. So we start with a basic, standard econometric model of country-specific effects, where YIT is the under 5 mortality rate in country I at year T as a function of our coverage indicators and some covariates that may influence the under 5 mortality rates and coverage. For example, we include here in this vector income levels, demographics, education, and we also include, in addition to the country-specific effects, year effects to capture macro common changes. And the particular measures of coverage that we use depend on the particular analysis that we are doing. So to investigate whether progress towards universal coverage increases or improves child health, we look at the levels and the shares of pooled prepaid spending in the financing of the system. When we want to assess whether the health impacts vary according to how equitable countries are, we include in this vector the share of pooled health expenditure in the financing of the system, and we interact this share also with several measures of equity and poverty that I'm going to describe very soon. So this is the basic model. And in principle, we could estimate this model by fixed effects, but then it would give us very limited ability to deal with endogeneity of coverage measures, particularly with regards to simultaneity. So we estimate this model by instrumental variables in two steps. So in the first step, we directly estimate the reverse causal effect of under 5 mortality on each coverage indicator by using an equivalent of equation 1, but with each coverage indicator as a separate dependent variable as a function of mortality rates. Now, we are arguing that there may be simultaneity in this relationship, so we can't estimate this model consistently using least squares or fixed effects, so we need to use instrumental variables here as well. And for that, we need good instruments for mortality rates. In other words, we need sources of variation in under 5 mortality that are correlated with our coverage measures, so pooled health expenditures, primarily through their effects on mortality. And we use two instruments that arguably fit the bill. The first one is the annual level of CO2 emissions per capita in the country, and the second one is the number of conflict deaths in national and international conflicts. CO2 emissions may be related to mortality in opposite ways in principle. Higher air pollution has been linked to a higher incidence of respiratory diseases and other potential fatal conditions on infants. So there may be a positive association between higher CO2 emissions and higher under 5 mortality. But we can also think of CO2 emissions as being a proxy for larger urban agglomerations, which tend to be less exposed to some communicable diseases, waterborne disease, for example, and a lower risk of contagion by those conditions, thereby leading to reduced mortality by those conditions, or reduced under 5 mortality. So there may be a negative relationship here. This is an empirical question. I mean, we just need that CO2 emissions changes levels of under 5 mortality. And the other instrument is the number of conflict deaths. And obviously, they represent a relatively small share of overall mortality levels in our sample, but they tend to be more correlated with under 5 mortality, obviously in those countries that, where conflicts have been more frequent during the period of analysis. And these tend to be sub-Saharan African countries and the Middle East. So the assumption we make is that variations in CO2 emissions per capita and the number of conflict deaths will induce differences in under 5 mortality rates across countries, which will in turn trigger a response in terms of our coverage measures such as pooled health expenditures. And we argue that it makes sense to think of CO2 emissions and conflict deaths as affecting coverage primarily through their effects on mortality. For example, larger urban agglomerations may induce reduced mortality because of respiratory diseases and so on. And this may provide an incentive to governments to move resources away from the health sector, so resources that were used to treat those conditions, and use those resources in other areas of public policy that may be more pressing, for example, housing infrastructure. And even though higher levels of CO2 emissions may be correlated with GDP, with the levels of national income, all our regressions include GDP per capita. So if there is any indirect effect of CO2 emissions on our coverage measures through levels of national income, we are going to capture it by the inclusion of GDP per capita in the regressions, and it shouldn't invalidate our instrument. And the second instrument that we use, conflict deaths, countries that have been recently involved in international or national conflicts, they tend to receive enhanced support to their healthcare sectors by international donors, channeled also through government, and they tend to increase their spending on health from domestic sources when feasible, thereby increasing the level of pooled health expenditures as a response to the worsening in health conditions. So these are and again, any effects of conflict deaths that come through changes in GDP per capita or in income levels are going to be captured by the inclusion of GDP in this vector here. So we argue more intuitively in favor of these instruments, but in the paper we also provide several regression-based tests that provide support to the exogeneity and the validity of these instruments. And these include basic Hansen tests for exogeneity of the instruments, but we also do a lot of testing for reduced form. So for example, we take one instrument at a time and use the other instrument as covariate to see whether there is any direct effect on our coverage indicators, and we don't find any evidence that there is. So it seems that in addition to an intuitive reason for those instruments, there seems to be regression-based support for them as well. And then we take those two instruments and we use them in a GMM context to obtain consistent estimates of this lambda guy here, which is the reverse causal effect of mortality on pooled expenditures, on our coverage indicators. We take then this estimated reverse causal effect. So we take that lambda, that reverse causal effect, in the second step, and we use it to construct just a series of coverage indicators that are free from reverse causality. And how do we do that? So we take the estimated reverse causal effect and subtract it from the observed level of pooled health expenditures. So we have here the observed value of pooled expenditure per capita. We subtract the estimated reverse causal effect of mortality on that one, and we end up with this variable C star here, which is the level of pooled expenditures expunged from reverse causality. And then we take this generated variable and we use it as an instrument for the variable that we want to estimate here. So we take that generated C star and use it as an instrument for the observed value of coverage here. And the idea here is to use that instrument to obtain a consistent estimate of beta, which is actually the parameter that we want to estimate, which is the effect of pooled expenditure or on under 5 mortality. By construction, this generated instrument is free from reverse causality, and it's also going to give us consistent estimates of our parameter beta here if the error terms in this equation 1 and 2 here are uncorrelated. In other words, if there remains no omitted variable bias in the estimations. Of course, this is an assumption. We can't directly test it, but what we do in the paper is to try and alleviate concerns by including a lot of time-varying regressors that may be correlated with coverage and health outcomes. And we also provide in the paper a series of robustness checks, including changing the instrument set to see whether the coefficients are stable, and they pass all the tests. So it seems that we are in the right track. So then we take this estimate, the generated instruments, and we try and obtain a consistent estimate of the beta parameter using two-stage least squares. Okay? So this is all the econometric firework that we do in the paper. So this is basically the spine for the empirical analysis. And now I'm going to give you an introduction to the data that we use. So we gather the most comprehensive panel data set available from sources like IHME, Global Health Data Project, and we also take data from WHO and the World Bank for 160 countries observed during the period 1995 to 2011, so 17 years worth of data. So it's a relatively long time series. And this table here presents the descriptives for the full sample and for specifically for the sample of low and middle income countries. And there are no surprises here in the descriptives. So under 5 mortality rate is around 45 deaths per 1,000 in the whole sample, and it tends to be higher for low and middle income countries. No surprise here. Pooled health spending per capita on average is around $700. These are PPP adjusted. But it's far lower for the group of low and middle income countries, again, as expected. Pooled health expenditures represent around 2/3 of total health spending. Smaller share for low and middle income countries with a lot of variation. So there are many low and middle income countries with very small shares of pooled health expenditure in the total financing of the system. And we also use several indicators of equity and poverty to try and see whether the health impacts of our coverage indicators vary according to these. These include differences in skilled birth attendance across urban and rural populations, highest and lowest wealth indices, difference in access to piped water, sanitation, primary school enrollment, and we also include 2 measures of the incidence and depth of poverty as well. I think one of the main limitations that we face in this work is the fact that these equity and poverty measures, they are normally available at one point in time for most of those countries. In some of those countries, we have 2 points in time. But basically, for the analysis in which we interact these variables with pooled health expenditure, these variables here, they are basically time invariant. So there's one limitation in the data that we can do nothing about. Okay, so this is the data. So let's go to the beef now, which is basically what we find when we do all the econometric firework there. This table here presents the main results from our from the second step of our IV approach. So when we use that those generated instruments free from reverse causality to estimate the effects of pooled spending on under 5 mortality. What we find here, the first result that we find, is that progress towards universal coverage measured by higher levels of pooled expenditure per capita causally leads to better child outcomes, to lower child mortality. And this result remains even if we control in the regressions for the level of private out-of-pocket spending per capita, which is, according to the estimations, isn't related to child mortality significantly, and even if we control for the quality of governance and institutions in those countries. So the quality of governance is negatively correlated with under 5 mortality, as one would expect. So countries that have better governance tend to have lower under 5 mortality rates. But this doesn't change the result, the main result that we were looking for here. And this is this coefficient here in column 2. The interpretation is the following. If a country increases their level of spending per capita by $10, on average, the country will see a reduction of 1.4 deaths per 1,000 in the under 5 mortality rate. So for a $10 increase in pooled spending per capita, a reduction in around 1.4 deaths per 1,000 in the under 5 mortality. And one very important thing about this result is that I mentioned before that in the first step, we tried to estimate the reverse causal effect of mortality on coverage. We find from these first stage regressions that governments tend to react to changes in under 5 mortality by changing their levels of pooled health expenditure. We find a positive, large and significant coefficient indicating that governments increase their levels of pooled health expenditure when they see their levels of under 5 mortality going up. So if we don't take that response into account, if we don't take the governmental response in terms of pooled health expenditures, and we estimate these by using least squares or fixed effects, we actually are going to find coefficients that are biased towards 0 or positive values. So in other words, if we don't take into account reverse causality, the cards are going to be stacked against finding any beneficial effects of pooled expenditures on health outcomes. So I think this is one important result that corroborates what we found in a previous analysis, and it provides some explanation for the lack of, or the ambiguous results that were found in some of the literature. Yes, please.
To clarify, is this point estimate still negative, though, when you estimate the ALS?
I'm sorry?
I'm curious if the point estimate is still negative when you estimate the ALS.
If it's still negative. In the analysis that we did, actually, we get a positive coefficient. If you use a model which is fixed effects, and we don't account for that, we get a positive coefficient, but it's small but positive sign. And then this is, so okay, so the first conclusion here from this table is that higher levels of pooled expenditure tend to lead to better child outcomes. But and this again corroborates some previous results for a shorter time series, but this result here in the third column suggests that the picture is a little bit more nuanced. For example, when we look at the share of pooled expenditure in the financing of the system, controlling for the total level of health spending, even though we find a negative coefficient, this coefficient is small in size and statistically insignificant. So there doesn't seem to be a direct effect here of the share of pooled spending on under 5 mortality. One possible reason for that is that this average coefficient may be hiding a lot of variation between countries. For example, countries that perform better in terms of ensuring wider access to their health system may be more able to translate higher pooled health financing into better outcomes. Whereas countries that perform badly in terms of equity of access to the system or other social determinants of health may actually find it very difficult to translate additional pooled spending into better outcomes, because that additional spending is captured by smaller sections of the population. So in population terms, you don't see any effects on the under 5 mortality rates. And we try to look into that in this next table here, when we do the analysis using pooled health expenditure interacted with indicators of equity of access to care and other social determinants of health. This table here, it uses the same methodology, the instrumental variables methodology that I explained before, and the coefficients give the marginal effect for a 10 percentage point increase in the share of pooled spending. And an increase of 10 percentage points in the share of pooled spending in our sample has a very nice interpretation. It's equivalent of a country moving from the average share of pooled prepayment in the low income group and moving up to the share that is found in the group of upper middle income countries. So it's moving from one end of the distribution to the other end of low and middle income countries. And the first result that we find here is that countries that are more equitable in terms of access to their health system tend to find more benefits in terms of health outcomes when they increase their shares of pooled expenditure. So for example, if we proxy access to the health system by differences in skilled birth attendance between urban and rural populations or the rich and the poor, we find that those countries, for the same increase of 10 percentage points in the share of pooled spending, those countries that belong to the group of most equitable countries, those countries that are in the bottom half of differences in skilled birth attendance, they tend to see reductions in under 5 mortality rate that are around 7 deaths per 1,000 larger than any gains that the least equitable countries get from increasing the share of pooled spending. So again, they get higher impacts for the same increase in the share of pooled spending if they are in the group of more equitable countries. And it doesn't seem to be the case that it's only equity of access to the system that matters. When we look at indicators of social determinants of health that may influence patterns of access to care, we find, for example, that those countries that are more equitable in terms of access to piped water sources or primary school enrollment, they also tend to see larger health gains for the same increase in the share of pooled prepayment compared to what the least equitable countries achieve. And the third result that we find, looking at these measures of the incidence and depth of poverty, is that countries that perform better in terms of poverty indicators also tend to see larger reductions in under 5 mortality for the same increase in pooled prepaid spending. And this result is important because some studies, they have found that poorer countries tend to benefit more from higher shares of pooled prepaid spending than do richer countries. Even in our previous work, we tend to find that poorer countries get larger health gains from increasing the share of pooled prepaid spending. But what this result suggests is that the picture is a little bit more nuanced in the sense that pooled spending will only have its health gains maximized if poverty isn't so severe so as to prevent most vulnerable citizens from accessing the health system and benefiting from this additional public spending. I don't show it here, but there is a huge difference between the countries in the bottom half of the poverty gap, for example, and countries in the top half. So we're comparing groups of countries in which the poverty indicators are very dissimilar. So the countries that perform badly, they perform really bad in terms of the poverty measures. So what we are seeing here is basically it's not every poor country that's going to find large health gains from improved share of pooled prepayment. There is a limit. So if poverty is so widespread that most people actually can't get to the system because, for example, of too high opportunity costs in terms of foregone wages or transportation costs, then those health gains are going to be captured mainly by smaller sections of the population. And we, in this last column, actually, we just show that if we don't take into account these measures of equity of access to the system or social determinants of health, the results for the share of pooled spending will tend to be small or statistically significant, which is what we found in the previous table. So it's not increasing the share of prepaid spending only, but it's also making progress in other areas, particularly in terms of equity of access. So just some conclusions, and then I'm going to open for discussion, and I look forward to any comments there. So even though this is work in progress, as I mentioned, and there are important limitations to the data that we were able to gather, I think that there are some tentative conclusions that are important from here. And the first conclusion is that progress towards universal coverage measured by higher levels of pooled prepaid spending does seem to improve population health, at least measured by under 5 mortality rates. Not only are there likely gains in terms of financial protection if countries rely more on pooled health spending, but pooled health spending is more efficient in generating health gains than out-of-pocket spending. So our results for out-of-pocket spending show that there is no impact of increased out-of-pocket spending on child mortality. A second conclusion is that countries will only be able to maximize the bang from their pooled health bucks if they ensure that the most vulnerable populations do have access to the health system, to subsidize healthcare. Now, this may seem that obvious, but there isn't much quantitative evidence on the topic around. So I think that this is one important message of the work. And a third message so far is that the health systems are probably going to be unable to maximize the gains from transition to universal coverage in isolation from other areas of government policy, such as housing, education, or poverty relief. Again, this may sound obvious, but there isn't much evidence around on that. And this highlights one thing, which is the need of concerted policy efforts at the national level. It's not only by making progress in terms of increasing the share of pooled expenditure that is going to translate those additional funds into better outcomes, but it's making progress in other areas as well, including poverty relief. And it's probably a two-way road as well, in terms of that if countries make progress in terms of equity of access by improving pooled health spending, for example, they are going to see benefits in other areas as well, for example, by reduced impoverishment due to healthcare payments. So it's a two-way road, and it highlights the importance of these concerted policy efforts. Again, this is work in progress. There's still some work to be done, particularly in terms of measures of equity that we want to look at. Some of these measures are highly correlated with each other, so we have to be a little bit careful in terms of the interpretation for each and every one of them. But in sum, I think that there are some valuable messages that this empirical exercise has brought about. So I'm going to leave it there and open for discussions. Looking forward to any comments. And in the meantime, thank you very much for the attention. Don't be shy. Please.
You know, I believe I might have gotten this wrong. You talk about how a $10 or $100, maybe it's a $10 increase in spending would result in 1.7 fewer child deaths per thousand, I think. And it seems to me that that relationship would be very different in a country with, say, 10 child deaths per thousand as opposed to a country with 100 child deaths per thousand. Can you comment on that?
Yeah, okay. So the question is about the differences in the average effects that we present here according to levels of under 5 mortality. Yeah, so one important thing to mention here in all these results is that they are average marginal effects. So we're talking about mixing up a lot of different countries there. So this is what would happen on average for a given country. We didn't do any particular analysis for non-linearities in this relationship. It's something that we are planning to do. So it would address the concern that you just mentioned. But so far, we've just stuck to these average marginal effects. I would expect that there would be differences there, of course. I mean, there are, in under 5 mortality, or when you look at infant mortality, there is a high component, which is, for example, perinatal or neonatal, in which actually, even if you keep pouring money there, there are some death conditions that are unavoidable. So it's not that the health system is going to sort it out. So you would expect that countries with lower levels of under 5 mortality will see lower marginal gains from additional pooled expenditure. This is something that we would like to have a look at, but at the moment we haven't. Yes, please.
Was my right that one of your conclusions was that the effect of pooled prepaid health spending is greater in countries with greater government?
The conclusion from this here is actually a little bit, well, it's a little bit different actually. Here, the governance index isn't interactive with anything. Yeah, so this is just to say what this coefficient is saying is that countries that are better governed, they tend to have lower levels of under 5 mortality. When we did the first analysis interacting governance with pooled spending, we haven't found any significant effects. So that's why I don't present it here. Okay, yes, please.
Follow-up to the first question is if in the case where there's some baseline level of say under 5 mortality and you wouldn't see an impact then of pooled spending, what would be a better indicator of health that you would expect there to be, that you would expect to see a difference in because of the pooled spending?
Yeah, that's a question that we've been discussing, because one of the things that we want to do is to look at specific indicators for specific conditions that you would expect there would be. I mean, there is some literature, for example, some work by Martin McKee and others who look at meanable mortality. So, so the conditions where you expect that the health system will have a bigger influence, and this, for example, they get to conclusions that for cardiovascular diseases, you would expect at least 50% of those deaths to be preventable by the health system, for example. So you could extend this analysis by looking at those particular conditions. IHME would be a particularly good source for this kind of data for particular conditions, but we haven't gone so far. So the data we gather, I mean, we're particularly limited for the fact that we needed data for the whole period, so and for as many countries as we could get. So under 5 mortality, which is actually IHME data on under 5 mortality, was the one that we chose. In the previous analysis that we did, we looked at adult mortality rates as well, so overall male and female mortality rates. But these are, again, overall mortality rates. They don't include specific conditions. But I think the question is a very good one. I mean, we haven't gone that far yet. Yes, please.
Could you talk more about your choice of using CO2 emissions?
Yeah.
As your instrumental variable, and then especially more about like how it directly yet independently affects under 5 mortality.
Yeah.
Because you said something along the lines of, you know, areas with high CO2 emissions probably have low risk of waterborne diseases, etc. But I feel like that sort of still connects to things like coverage for various other things. So I was wondering more, how did you rationalize these?
Okay. Right. So the question is about the instruments that we use. Let me go back. So, and in particular about the reasoning for using CO2 emissions per capita. Well, what we need in this case, I mean, let me go back one step, is just say why we're looking for instruments for mortality. I mean, we were particularly interested in there is a lot of talk about this potential simultaneity and reverse causality. So we want to get at this issue. And so one way of doing it is by using this 2-step approach. And for that, for this particular 2-step approach, we need instruments for mortality and not for coverage indicators, which would be the most obvious way of thinking. So in terms of mortality, we need sources of variation in under 5 mortality, which you could think that affect our coverage indicators of pooled expenditures primarily through changing levels of population health, basically. That's what we want. And the CO2 emissions, first they have to be, for CO2 emissions to be a good instrument, first it has to be correlated with mortality. Whether it drives mortality up or down, again, is an empirical question. We just needed to shift mortality levels. And it can be correlated both ways with mortality, at least in principle. So I could think that, you know, a higher air pollution leads to a higher risk of respiratory diseases and other fatal conditions, and then you would see a positive relationship between CO2 emissions and under 5 mortality. But you could also think, and there is some literature in the topic showing that, well, if countries are more urbanized, they tend to have a larger, higher levels of CO2 emissions. And those CO2 emissions actually end up being serving as a proxy for these larger urban agglomerations. And the question is that in larger urban agglomerations, as countries get more urbanized, the incidence of communicable diseases and some waterborne diseases, the risks get lower. So you could see a negative relationship, actually. So reduction in under 5 mortality, which is particularly affected by some of those conditions, and CO2 emissions. So this is to say about the relevance of the instrument. In terms of the validity of the instrument, what we argue is that if you think in the case of larger urban agglomerations, what we are saying is that larger urban agglomerations may induce this change in mortality, so may reduce under 5 mortality because now people are less exposed to this waterborne disease or other conditions. And then seeing that the fatality of those conditions and the incidence of those conditions has decreased, governments may feel more free to transfer some of those resources away from the health sector towards other areas. And then, so the response in terms of pooled health expenditures comes from the visualization of what's going on in terms of under 5 mortality rates. That's the basic rationale. One first thing that people tend to say when we make this rationale is that, well, actually, CO2 emissions are correlated with GDP. With the national levels of income. So countries that have higher levels of GDP, they tend to have higher CO2 emissions. And not only that, countries that have higher GDP also tend to have higher levels of pooled health expenditures, and that you have a problem. So the argument that we make is that, okay, but if we introduce GDP in the regressions, then any indirect effect that CO2 emissions may have through levels of national income are going to be captured by the introduction of this variable. And they shouldn't invalidate the instrument. So that's basically the argumentation that we do. And it goes more or less the same way for conflict deaths. I think I had a question.
Just sort of a follow-up to that. It seems logical that you would then standardize that by population density. So I'm sure that CO2 emissions per capita in North Dakota is really high, but their air quality is probably not so bad.
Yeah. That's
per capita in India and China may not be as high as some other places, even though the total or land area.
Yeah, we haven't done that. I think that's a good idea and a good test of the instrument. So I think that's a good idea. We haven't done it. Yeah. No. Yes, please.
This is also related to this.
Yeah.
I'm curious. So I don't quite follow your rationale because there's also with increasing urbanization, there's also increasing populations living in slums, which then have enormous exposure to communicable disease and waterborne disease. And so I'm not sure that it's so linear at the shape. I was wondering if you explore that at all.
No, yes. It might be. I mean, again, this is an empirical question. So in terms of our identification strategy, this isn't germane to the argument because what we need is just that it shifts under levels of under 5 mortality. We need that empirically it is correlated to levels of under 5 mortality, either positively or negatively. If that's the case, and obviously we do testing to check that out, whether in the first stage regressions we have a good predictive power of CO2 emissions on mortality, and it is the case in our sample, then that's good enough for us. That's what we need. We don't go further into exploring the chain in terms of causality from CO2 emissions to mortality. Yes.
That holds even if it's not a linear.
I'm sorry?
Then that holds even if it's not a linear correlation?
Yeah, I mean, it would have to be correlated. Again, it would have to bring a shift in levels of under 5 mortality. So that's what we need, basically. Yes, please. In lagging? Yeah, okay, yeah. Okay, so that's a very good question, and it's something that we've been debating with. To use so let me go back to the basic equation that we try to estimate. So what you are saying is that it would be interesting to take the lagged value of this and put it on the right-hand side. This raises one question, which is, it makes sense. I mean, so let me go back one step. The idea for doing this, one of the ideas would be to try and account for initial conditions in terms of under 5 mortality. If we think that we are using country-specific effects here, and initial conditions are time invariant, we are capturing that effect through the specific effects, the country-specific effects. But if we want to model a relationship that is more dynamic, as you are suggesting, then we need a different estimation strategy here, because we can't use country fixed effects to estimate these. We need, for example, to use a GMM system of equations, Arellano-Bon estimator. And I am not a big believer in this kind of instrumentation, just because empirically, in work that we did previously, we actually found that those instruments that are used, which tend to be instruments that come from the model itself, they tend to be very weakly correlated with the variable that we're trying to instrument, and also there is a lot of autocorrelation there that render those instruments invalid. So we haven't gone down that route. We did it for the first paper, but just to please the referees, basically. And the referees seem to accept that in our sample, it wasn't a good strategy. I mean, empirically, it wasn't a good strategy. So, oh, yes, please.
Does this analysis answer or address the question of reducing or removing individual financial barriers results in better or worse health?
Yeah, I think it relates directly to the question, because pooled health expenditures, or the idea of pooled health expenditures, is precisely to avoid that people get to the system and they have to pay out of pocket for when they are most vulnerable, right? When they need medical care. So the main reason for the existence of pooled expenditures is to allow that people are going to be financially protected against financial consequence of it, against financial impoverishment because of that. So what I think one of the key messages of the analysis is that pooled expenditures have an effect that is being documented in terms of increasing financial protection, but it's not only that, that improved financial protection makes people healthier. Perhaps, I mean, the causal chain, we don't address the causal chain here, but some obvious links would be, well, if you have to think twice to go to the doctor because you're going to have to pay out of pocket, then you're probably going to delay your decision to go there, and you get to the system when actually you need more expensive health care, for example, and your health outcomes are going to be worse down the line. So one basic message of this is, yes, that more financial protection seems to be linked to better health.
But it's pooled, are you talking about public expenditures?
Well, the variable that we use is pooled expenditures, which includes government expenditure, but also private voluntary health insurance payments. But in practical terms, it's basically government expenditure, because the average of voluntary insurance payments in our sample is below 3%. So actually, payments for private insurance represent less than 3% of total expenditure, on average. When you take low and middle income countries, even lower, so it's around 1%. So we're basically talking about public expenditure.
Great, I believe we are out of time.